Good morning, everyone. Thank you so much for waiting for such a long time, and we are sincere apologies. Welcome to Oral Diagnosis and Oral Radiology, a weekend insight, weekend free webinar series, which is organized by AIMS University and Amropin India right now. And I'm Dr. Priyadarshini from Faculty of Dentistry from AIMS University, Malaysia. I'd like to thank our organizers, AIMS University, Malaysia, for giving us immense support and guidance throughout this program, and Amropin India for your abundant support from the beginning of this web topics. Yeah. Today's topic is what is monoclonal antibody therapy. It is by Prof. Dr. Nisheeth Saawaran. He's from India. Prof. Dr. Nisheeth Saawaran is a MDS. He is a Master's from Oral Medicine and Radiology. He is currently heading the department in Baba College of Dental Sciences from Baba University, Bhopal, India. He has completed his undergraduate and postgraduate degrees from Rajiv Gandhi University of Health Sciences, Karnataka, India, and is pursuing undergraduate and postgraduate teaching in dental schools of India since last 13 years. Dr. Nisheeth has passion for clinically oriented research and works mostly with the oral mucosal lesions like lichen planus and OSMF, which are frequently prevalent in India. He has about 30 international publications to his credit. He is also a reviewer board of many peer-reviewed journals and on the editorial board of a few. He will be sharing his knowledge about the role of monoclonal antibodies in the management of various lesions and conditions affecting the primarily oriented towards the clinical and the applied aspects. Before we start, let me introduce you the panelist, Prof. Vasanti. She has 13 years experience in oral diagnosis and radiology. She has introduced integrated teaching, flipped classroom, case-based learning programs. She develops programs in instruction, assessment, curriculum planning, and leadership. She is an internationally certified life coach. And next is Prof. Pinakapani. He is the head of the department from Government Dental College, Raipur. His area of interest is oral pre-malignant lesions, conditions, oral cancer, and orofacial pain. He is actively involved in the forensic odontology. And the third panelist for today is Dr. Shikha Khare. She is actively involved in CBCT reporting and 2D maxillofacial radiographs. Her pursues interest in academics and teaching the NEET MBS aspirants in India. And Dr. Nisheeth, and we introduced Dr. Nisheeth to start up with this talk regarding what the monoclonal antibody is all about. Thank you, Doctor.
Thank you. So I think I hope my screen is seen on the page. It is live. I welcome you all and I extend my heartfelt greetings from the city of lakes, Bhopal. Bhopal is the capital city of Madhya Pradesh province of India. It is voted the cleanest capital of the India and the second cleanest city in the entire country. This statue is of Raja Bhoj, who was the grandson of legendary King Vikramaditya, and he is the one who established the city. I work here in Bhava University, Bhopal. So welcome you all greetings from Bhopal. Now, these are two places which are very, places of reverence for me. One is the M.R. Ambedkar Dental College, Bangalore, India, from where I did my graduation. And I'm always thankful to all the teachers from that college who has taught me everything. And every day when I work in my clinic, I extend my gratitude and thanks to them and bow my head to them. The other is the Premium Institute, that is College of Dental Sciences, Davangere, Karnataka, again in India, from where I pursued my post-graduation in oral medicine and radiology. And I'm ever thankful to the staff of my department for making me eligible enough to achieve all this and to teach oral medicine radiology and see my patient's quality. I am thankful to my guide, Dr. Sashikant sir, my other teachers, Dr. N. Kannan, Dr. M. K. Sunil, Dr. Ali I.M., Dr. Shambhu Lingappa, Dr. Deepak, and Dr. Anupma madam. These two places are like temple for me, and I'm ever thankful to these two places. So coming to today's topic is monoclonal antibody therapy. It is a bit new emerging science, not much known to most of us, but I have been told that I have to keep the topic to the basic level, to the undergraduate level. So I am doing it in that way to keep it into the mere basics, so that the people can understand, the undergraduate students and the dental graduates, the general dental graduates and practitioners can understand it and utilize it there in practice, or can face the situations when they come across these medicines or the patients undergoing these therapies. So let's start with the introduction. Whenever there is some change in the physiology of our body, maybe it is by inner changes in physiology or by some external changes like some pathogens, then we start feeling uneasy, or the body gets disordered. So those conditions are called as disease or disorder. And when you try to set those things right, when you're trying to set the state of dis-ease from the state of ease, that entire process is called as a therapy. Now, the therapy can be in many ways. We can use a scalpel and a blade, and that is known as surgical therapy, where we remove the disease part. Or we can use some physical methods like a massage or a electric current or a TENS therapy. That is called as physical mode of therapy. Sometimes we use radiations to cure cancer, that is called as radiotherapy. And the most commonly used is the pharmacotherapy, where we use some chemical agents or some compounds which we just pop up or inject in our body. Those agents are called as pharmacological agents, and pharmacotherapy is the most prevalent and most commonly used mode of therapy. Pharmacotherapy is practiced by through many modes and many paths, like allopath, which we practice. Then we have homeopath, Unani, Ayurvedic, and so many. Most of them use the monoclonal pharmacotherapy. Among pharmacotherapy, there is a new group of drugs called as immunotherapy. Immunotherapy is where we modulate our immune system to work, where we make our immune system to work for us. That means it's like training our army to fight a certain kind of, to equip them with some special equipment and some special skills to fight against the enemy. So here we modulate our immune system to fight against the disease, and that is what is called as immunotherapy. Among immunotherapy, monoclonal antibody therapy is one of the mode of immunotherapy. Today we'll discuss the monoclonal antibody therapy in brief, especially pertaining to the dentistry and the oral medicine, because it is a very vast topic. So we'll confine ourselves mostly to the dentistry and oral medicine. There are a class of drugs or medications which use living organisms or synthetic versions of them, and they are manufactured by using recombinant DNA technology. Okay, not always, sometimes. Those drugs are called as biologics. Those are called as biological therapies. Biological therapies are any virus, any therapeutic. The Food and Drug Administration of USA defined this as any virus, therapeutic serum, toxin, antitoxin, and analogous product applicable to the prevention, treatment of cure of disease or disease of injuries of man. That's what is known as the, I'm sorry, 1 second please. I'm having some trouble with the screen. I don't know how to align it. Fine. Somehow, yes, it has come. Thank you. So basically, the biologics includes a large variety of things that we use in therapy, which includes blood and blood derived preparation, antitoxins, growth hormones, insulin, human genes, genetic therapy, all the hormonal supplements that we give, whichever is derived from directly from organisms, they are all biological. But when we talk about biological drugs in a strict sense or literally sense, then recently we consider it in the three ways. That is, the three parts are there for the biological drugs, or three kinds of drugs are considered under biological drugs. Those are called as cytokines, which are key signaling proteins, either monoclonal antibodies or fusion proteins. These three types of biological drugs are considered for the immunotherapy or biological therapy. Among these three, today we are going to discuss only about monoclonal antibodies. So I think we all know what are antibodies. Our body responds to pathogens in two ways, either T cell mediated immunity or cellular immunity, or through humoral immunity. Humoral immunity, we all know that is mediated by B cells, and it is here they produce antibodies which are highly specific and affinity to antigens. That is, it's kind of our body detects some protein as a foreign protein and prepares our army to fight with them. These antibodies are specialized proteins which are produced by B lymphocytes or plasma cells, and they have a special affinity for the antigens. Right, their process is to clearize either clear the pathogens and toxins or neutralize them. Their advantage is they have a specificity, they are specific, and not only that, they remember it. They remember the things, and they have a continual resistance to that particular antigen. So if today we have been exposed to one antigen, probably after 5 years also, if we get exposed to them, the antibody will be there present in our body for that, and it will react and act against it. It is like sensitizing it. So it also has it provides continual resistance to them. Now, these antibodies can be of two types. They can be either polyclonal or monoclonal. What do you mean by polyclonal antibodies? Polyclonal antibodies are those which are not specific to one particular antigen. Means most of the naturally produced antibodies in our body are most of the time polyclonal. That is, they act against a variety of antigens, while monoclonal antibody are like special wings of army, something like how we have sharpshooters or snipers. They are trained to target one single enemy. Or in if you see the different countries armies, they have some commando forces, some forces only for some protection of highly VIP people, some forces only for the protection of border at some places. So something like that. The monoclonal antibodies, their target is fixed. They are not bothered about other. Their target is fixed. They act specifically against one antigen, and that is their biggest advantage also. Why is that advantage? Because when they are not hindering or they are not interfering in the pathway of other works, then the side effects becomes limited. And such antibodies are known as monoclonal antibodies. Means they are obtained from a single clone. Monoclonal means they are obtained from a single clone, and they are produced by hybridomas. I'll explain what are hybridomas. They were first introduced in 1917 by Kohler and Milstein. The Kohler and Milstein, he thought that when the antibodies are formed in the body, why not utilize this antibody itself as a medication and introduce those antibodies inside our body so that they can go and fight the pathogen. Directly supplying the army. It's like, no, you have a war against you and you are buying army from somewhere else to fight with them. So Kohler and Milestone has started this hybridoma technique, and he has started producing and introduced this technique in 1975. Later, he got a Nobel Prize also for that. All the monoclonal antibodies are suffixed by MAB. Their name is suffixed by MAB, M-A-B. That stands for monoclonal antibody. Like for this example, this drug, omalizumab. This is a monoclonal antibody. So whenever you see a medicine naming ending with MAB, means you will know that this is a monoclonal antibody, and you will know what all precautions to take along with those medications. Okay. So they are produced. One technique is the hybridoma technique. I like told you. This is also called as mouse ascites technique. Or basically, what happens here that we take a mouse, and this spleen is sensitized by the antigen against which you want to prepare the antibody. Once we synthesize the spleen starts producing antibody. Then we trick the mouse body and we introduce myeloma cells. Myeloma cells are immortal cells. They do not die, they keep dividing, they do not die, and they themselves do not produce any proteins or antibodies. So these myeloma cells get fused with those mouse antibodies producing cells, and hence they are called as hybridoma cells. These hybridoma cells start producing monoclonal antibodies inside the mouse, around the mouse spleen, and stomach starts swelling. It is called as mouseitis. Now we can inoculate that monoclonal antibody from one mouse to another, to third and fourth, and we can produce those antibodies, retrieve it from the animal by killing it or by sacrificing it. That's a better term, and we can use it. Sometimes this fluid is again collected in vitro, and there it is put in the cell lines and cultured. So it becomes a mixture of in vivo and in vitro. The problem here is that the process is slow, it is bit tedious, and sometimes we will not get highly purified proteins as much as we desire, and animals need to be sacrificed, and they are put in pain before they are sacrificed. So there are a lot of ethical issues involved with it. So to overcome this, the recombinant DNA technology is being used, where everything is done in vitro. The animals are not used, animals are not sacrificed. There is no ethical issues. The bacteria have a property to display the antibody protein on their in their genome or on their cell membranes. So some bacteriophage viruses are used, and the genome is introduced inside that bacterial genome, and the desired antigen is introduced inside the bacterial genome or the antibody, and the antiphage, the bacteriophage, introduced, and it starts replicating. Later this is grown on the solid culture media. The benefit here is that it is very fast, there are no ethical issues, okay, and much more pure form of the and monoclonal antibodies are obtained. Nowadays most of the countries, western countries or the developed countries, are recommending recombinant DNA technology techniques, and in short they are called as RABs, that is recombinant antibodies. These are two methods. Now based on which animal is being used or which method the monoclonal antibodies are being formed, they are of four types. One is the murine type, that is where it is produced from the mouse. When the mouse is used, it is called as murine type. And how we will know that any monoclonal antibody is from the origin of murine origin? That is from their name. Their name will have a suffix called mo. If the suffix mo is present, like this drug, it is ibritomumab, then it is a drug produced by the murine antibodies. Okay, sorry, using mouse. The problem with the murine antibodies was that they had a very short half-life, and they were inducing allergic reactions inside the human body, and sometimes anti-drug proteins or the allergens were being produced. To overcome that, chimeric, humanized, and human monoclonal antibodies were used. The chimeric antibodies are those where many other animals are used, sometimes rabbits, rats, or even chicken or pig are being used. These chimeric antibodies have 50 to 90 up to 90% of the human genomes. No, they are partly humanized, that is 50 to 90% the human proteins are introduced, and they are known by the suffix, this word Z in between their names. So this apiximab is a chimeric antibody, right? XI word is introduced in with them. Then we have humanized monoclonal antibodies. They are up to 95% is the human protein, and they are known as omalizumab. That is the word ZU. Zu is there in between. So their example is omalizumab. And there are fully 100% human monoclonal antibodies. They are known as adalimumab. So there the example is adalimumab. Here the word MU is there. You can say it is taken from word human. No, so it is adalimumab. When there is a word MU in between, it is a human monoclonal antibodies. When there is a zoo in between, it is a humanized. When there is di in between, it is a chimeric. When there is a mo in between, it is murine antibody. This how we know. Then there are some other terms, Li, C2 here. Here also the word Li is for the inflammatory. That is this indicates that the disease for which it was originally planned to use. It's not necessary that it will use only against inflammatory, but the monoclonal antibodies for which they were originally planned or produced to be used, they were given this term. So when you see a term Li in between, before the term MO or XI, then it is known for the inflammatory reactions like Omalizumab means this was basically made as an anti-inflammatory. Adalimumab, it was basically an anti-inflammatory. Same, there is a word CIR or CI, then it is for cardiovascular, like Apiximab. It is made for the cardiovascular disorders. Or when there is a word TU, that is made for the tumors or neoplastic diseases like Ibritumumab. Then this drug has been made from a murine antibody, and it is made against the neoplastic disorders. Okay. Coming next, this is the government's one website, International Immunogenetics Information System. It is an international authenticated form which provides information regarding all the genetic and immunotherapies. If you go to this website and you see the recent data, they say that there are 30 monoclonal antibodies which have been approved to be used as a therapy. There are more than 100 which are within trial at different phases of trial, out of which 30 have been approved. However, this chart by them shows 52 antibodies which have been approved. Either I have missed some information, or there's some information link is missing there, or something else is there. Anyways, out of these 52, 5 are murine antibodies, 7 are chimeric antibodies, 18 are humanized antibodies, and 22 are human antibodies which are being used in therapy. If you go to this website imgt.org and search for monoclonal antibodies, they will give you the entire data of all the monoclonal antibodies which are under various phases of trial. They are being used for which disease, produced from where, by which company, at which phase of trial, and what is the status. The entire data can be obtained from there. So those who are interested can visit the site and they can get all the recent data. Now see, we'll see how are monoclonal antibodies different from the traditional traditional pharmaceutical agents. Like what is the difference between the normal medicines that we take and the monoclonal antibodies that we take? Like how is this egg is different? This egg is brown in color, others are white in color. It's so obvious. So there are 4 ways in which they differ. The route of administration, the traditional drugs, or the normally what drugs we use, they can be either parenteral route of administration or they can be oral route of administration, while the monoclonal antibodies are always parenteral. There is no point in eating antibodies, right? The antibodies need to be present inside the blood, so we have to inject it inside the blood. We don't want to eat it. It's not it's a protein. If you eat it, it will get digested. You will not get anything. Okay. Same way is the metabolism. Most of the traditional drugs are metabolized with reactive intermediates. We all know that drugs are metabolized in liver or kidney or some other part of the body. Some are they just disintegrate into different forms. They comes in the huge pharmacokinetics and pharmacodynamics of drugs. While the monoclonal antibodies are not metabolized, they are not need to metabolize. They are directly the antibodies which need to be injected inside the body and they need to fight. All the traditional drugs are synthetic materials, while biological drugs are similar to native proteins. They are not synthetic, right? Their body accepts them as a part of their own. It is a human protein, which is sometimes 100% human proteins. So body accepts as a part of them. They are not synthetic chemicals. And based on these, since they are metabolized, there may be various intermediate stages. So we may have different kinds of adverse reactions. We may have immune-mediated side effects, which may be unexpected or unlike what we have thought. And sometimes we face it. All of us, when we treat medicine, sometimes we face with very weird and unexpected allergic reactions. Most of them are T-cell mediated. They may be drug-drug interaction. A patient is taking one drug, we give another drug. They have to be synergistic effects, antagonistic effects, various types of effects. There may be toxicity, which are not there in the monoclonal antibodies. Where there we see only immune-mediated effects or immunoglobulin mediated effects, or sometimes hypersensitivity will be seen. So this is how monoclonal antibodies and traditional drugs differ. I think till now we have understood this. Now we'll see how they function. We know that it is usually said that our immune system does not act against cancer, or the cancer cells evade the immune system. It is not clearly known. Maybe it is possible that our immune system is able to detect cancer cells, developing cancer cells, and most of the cancer cells die, and they are not given a chance to grow, and we survive and we are safe. But still, nevertheless, many neoplastic cells, they change their structure, they change their immunogenicity, they change their surface antigen or some proteins, and they evade this immune system and start multiplying in our body and start forming neoplasia. So these monoclonal antibodies, which are targeted against these neoplastic cells, they are acting by either binding with a specific molecular targets on those antigens. That is, we take the neoplastic cells, we identify the antigens over them which we can target, and then we produce monoclonal antibodies against them. Or they go and block their signaling pathways, right? They block their signaling system and pathways, so their growth is hampered, or metastasis is hampered, or angiogenesis is hampered, or they start doing apoptosis. So that is how it acts in the cancer cells or neoplastic cells. This is very basic, brief introduction. If you go in detail, a book can be written on this. So I am not going in so detail, right? Then sometimes the monoclonal antibodies themselves are not enough. Like you buy a fighter jet, but sometimes only the jet will not be enough. You need to have some missiles, or sometimes those missiles need to have nuclear warheads. Those are called as payloads. We all know that if we have a nuclear warhead on a missile, it is called as a payload. Or the fighter crafts come with equipped various types of bombs and missiles. They are called as payloads. So same way, we also equip our monoclonal antibodies with various payloads. They are attached with some radioisotopes, toxins, or cytokines, or some chemicals, and they become more effective. Like the army, they become more effective. They can be either chemo-labeled. If they are chemo-labeled, one example is brentuximab. Right, brentuximab, it is a chemo-level vedotin. Brentuximab is chemo-labeled with the vedotin. It is used in Hodgkin's lymphoma. Or they can be radio-labeled, like betrimomab can be radio-labeled with Piozectan, and it is used in NHL, non-Hodgkin's lymphoma. I like to tell one thing here, I missed in the last slide, that monoclonal antibodies usually work very well with the hematological malignancies. In hematological malignancy, they show a very good result. Why is that so? Because the penetration is good over there. The penetration in hematological malignancies is very good. So they show a better result in the hematological malignancy, and they are seeing more successful results in hematological malignancy when compared to the other neoplasias. Okay. Then there is other method of autoimmune disorders, right? That is, in autoimmune disorders, they are used as a adjuvant immunosuppressive agents, right? In you know that they are immunotherapy, so they are anyway going to fiddle with the immunity of our body. So we can use them as a agent. We can use tactically to alter our immunity in such a way that it is beneficial to us when we desire. So when the regular immunosuppressive drugs are not working, that time we use monoclonal antibodies as a adjuvant to them, or as a replacement to them in the such cases where there are no resistant or recalcitrant cases. Here I am giving examples of some commonly used monoclonal antibodies, their indications and their adverse effects. Like you see this drug called adalimumab. It is human origin, or the human monoclonal antibody. It is against anti-inflammatory. The name LI says, so that's why the indication is rheumatoid arthritis or juvenile idiopathic arthritis. The adverse effects are serious infection, lymphomas, malignancies, hypersensitivity, hepatitis B virus infection, demyelinating disease, cytopenia, congestive heart failure, lupus. Like, the monoclonal antibodies come with a whole lot of adverse effects. The normal adverse effects, what we see, skin rashes, vomiting, diarrhea, headache, fever, malaise, all those are common. Along with that, we may have various kind of the liver functions are hampered. There is a hampered liver functions. There are the blood picture is altered many times. If the liver function is altered, automatically the person's bleeding, clotting time, and severe proteins, digestion, everything will be altered. Right? It is a very important organ. Sometimes heart failures occur, and many lesions are seen. Skin lesions like node erection is very commonly seen. Lupus-like syndromes are seen, and sometimes the neoplasia develops. Now there is a controversy here. People say that with monoclonal antibodies that there are chances of developing neoplasia, but some people say that those neoplasia were already present inside the body or developing inside the body, and we just noticed this after the screening became with monoclonal antibody therapy, because most of the neoplasia which develop are seen in the early phases of therapy. Nevertheless, we'll continue. This is another drug called tocilizumab. This is a humanized antibody, and it is again anti-inflammatory. It is again acting as rheumatoid arthritis. And here the gastrointestinal perforation is seen, immune suppression is seen, hypersensitivity reaction is seen, demyelinating disorders of CNS are seen, which is very alarming. And there again there is a active hepatic diseases occurs. They are not safe in pregnancy. Monoclonal antibodies are usually not recommended in pregnant and lactating mothers, because the proper safety studies are not available. Sometimes miscarriage or no deformed organogenesis has been seen in the fetus, so it is advised not to use them. Now there is another one, brentuximab. It is of chimeric origin and it is against tumor, so it is used against Hodgkin's lymphoma. Okay, it is neutropenia, peripheral sensory neuropathy, fatigue, nausea, anemia, upper respiratory tract infection, diarrhea, pyrexia, rash, thrombocytopenia, Steven-Johnson syndrome, embryo-fetal toxicity. Right, there are so many adverse effects which occur. And there we have it, daclizumab, I'm sorry. This is again humanized and again anti-inflammatory. So to use in the prophylaxis of acute organ rejection in patients receiving renal transplantation. In renal transplant patients or any transplant patient, we use it as an adjuvant to immunosuppressant drugs. But see the a vast array of adverse effects are occurring. There is a, other than the normal, all these abdominal distension, epigastric pain and nausea, constipation, we have edema in extremities, edema, tremor, headache, oliguria, dysuria, renal tubular necrosis, post-traumatic pain, chest pain, fever, pain, hypertension, hypotension, dyspnea, pulmonary edema, coughing, impaired wound healing, right, acne, musculoskeletal pain, and so on. Like that, the list is long. Ibritumumab is used for the relapsed or refractory low-grade follicular NHL. Basiliximab is used for the prophylaxis of acute organ rejection in patients receiving renal transplantation. Then we have muromonab. This is a mouse or murine antibody, right, which is used against the treatment of allograft rejection in renal transplantation. Abciximab, which is used against the stable angina, right? The word CI I told you starts for the cardiovascular. Z is the chimeric origin. It is used for the unstable angina, not corresponding to conventional medical therapies. Okay, but here we can have intracranial hemorrhage, stroke, or thrombocytopenia. Right, same way we have muromonab CD3, which is against used in acute allograft rejections. The list is long. I am not reading everybody. If you want, you can always refer the slides later. Okay, now we come to other way around, that is seeing for which drug which are being used. I'm going to just name the drugs here for the diseases which are being used. The diseases which are having oral manifestations or relate to or are of interest to dentists or the oral medicine specialists, I will be discussing it later in the next section in detail. Like for Sjogren syndrome, we can have rituximab, epratuzumab, belimumab, and infliximab. For pemphigus, rituximab is a widely used drug. It is on very good success result. For pemphigoid, we use omalizumab and rituximab. For chronic rhinosinusitis, we use omalizumab, mepolizumab, and reslizumab. For multiple myeloma, eltuzumab and the daratumumab is used. For psoriasis, ifseximumab, and one drug, I think one new drug has come, some itomumab or something, which has been, yes, it's called itolizumab, is again used for psoriasis, which now recently has been proved for COVID, it seems. And then for multi-drug resistant infections, we use papanobacumab. No, but tricky names. It's difficult to remember also. And then for demyelinating disease, we have daclizumab. For migraine, we have glycinazumab. For follicular lymphomas, we have rituximab. For chronic lymphocytic leukemia, we have almetuzumab or gametuzumab. For aggressive lymphomas, we have rituximab with the radio-labeled monoclonal antibodies. Remember, I told you about the payloads. And for hemostasis and coagulation disorders, we have rituximab. And for asthma, we are using omalizumab. Most of these drugs are not, some of them are under trial. Some of them, these have been taken from the various case reports or systemic reviews. I can't tell you that all of them are giving 100% results in all these diseases. Some are showing 60%, some are showing 60-70%, then some are having good results. Some are having controversy. Some authors are saying they are giving, some authors are saying not really. Nevertheless, I have named the drugs which have been used in them with varying success rate or they are under study in the different phases of clinical trials. Okay. To show you this, this is a World Heritage Site near Bhopal. It is called as Bhim-Betka. Literally it means where the Bhim used to sit. Bhim is a character in Mahabharata. Basically, it is a prehistoric caves are here where there are signs that the early human in the Paleolithic and Mesolithic period used to stay there. Even prior to that, not very well known. It is on the top of a hill, and in there you can see these multi-storied caves. These multi-story caves, probably that time also they had the desire to stay in first floor, second floor, and third floor. There are caves like that. People who have come to MP or India would have seen it. It is a world that is worth seeing it. What is most fascinating over here is that there are no all those areas, Paleolithic areas and Mesolithic area, even some recent areas. Recent means not a few years back, few thousand years back. So the wall paintings are there made by those early humans. If you see, there are signs of either hunting. People are going for hunting. Here, one hunt has been done. Here, there is either there is a marriage party, a war, or a hunt. Here, there is a group of animals. You can see all the deers and all have been. And again, one person can be seen hunting here. And here, some people are seeing board games. So that time also board games were there. People used to play and they had rules. For hunting also, I think they are following rules. Here also they are following rules. So rules are there, everybody. Rules were then there, then also rules are now also. From the time of hunting in the caves or hunting in the forest and staying in caves to we have come to stage where we are directly injecting antibodies in a human and trying to fight the disease. So from fighting to external animals in a chaotic way to the fighting the internal animals in a more organized way have come. And they all call for rules, and there are rules for the application of monoclonal antibodies too. So I'm giving you what are the usage guidelines for these biological drugs. They are not applicable only for monoclonal, they are used for all biologics, that is the cytokines and fusion proteins as well. They are indicated only when there is a severe disease as measured by the objective measurements of the various all disease. We use for many diseases there are scores 1, 2, 3, and when we say that your score is within 5 or 7, they are considered as a mild, moderate, or severe. So they are mostly recommended only for the severe diseases by the objective and subjective measurements of the diseases. One. Second, they are indicated only when the patients are refractory to or intolerant to conventional systemic therapy, or where the conventional systemic therapy is contraindicated, where it is not indicated. And third and most important, patient should be fully informed and a proper informed consent to be taken that this is not an established line of drug. This is an off-label drug. We are going to use it on you. You may benefit, you may not benefit, whatever it may be done. Why are these guidelines made? Because the cost is very high here. For some medicines, it comes to 8 to 10,000 euro per annum, or sometimes even more. It comes as a very huge cost. So both cost and there is potential risk for adverse effects for long-term usage, and their utilization with conventional immunosuppressants is not so well known. So we are taking a caution kind of thing, and we hope that as the things improve and the efficacy is known, more better safety data comes, these criteria will be revised and they will become more liberal. Okay. While so consideration of these guidelines and guidance to the licensed use of biologicals would seem essential for their use in off-label situations, including any use in the oral medicine with lack of quality data. With lack of quality data to support the use of biologics in oral mucosal disease means that formal guidance for such use is generally unavailable. An exception being guidance for Germany on the use of rituximab in vesicular disease. What I mean to say that since there is not much research in the field of oral medicine, there are not very good guidelines for the users in the oral medicine. They are not well known. Still, we should follow the guidelines which have been given by the medical fraternity and try to follow them. Except only for by Germany, the uses of there is a guidelines have been given for the use of rituximab in the vesicular diseases. Okay. So what are these guidelines? I have already told you where they are indicated. Now see where they are not indicated. That's what are the contraindications. If there is a hypersensitivity, if there is patient has acute infections, if the patient has severe heart failure, there's a pregnancy or lactation already due, if the patient has already demyelinating disease, because demyelinating disease occurs in the TNF alpha inhibitors, on if there is active or recent history of malignancies, right? Because already told you that there are chances of development of malignancies. So usually they are not indicated unless until they are being used for the cancer treatment or neoplasia treatment. But other drugs like if you want to use for rheumatoid arthritis or that patient has a carcinoma, you should not be using it. Okay. Now, what all screening we should do before starting the treatment, right? Proper history and physical examination is essential. I think that is there in it is integrated in our bloods. We always do that. full risk benefit ratio has to be assessed, risk and benefit ratios to be assessed properly. The patient's full blood picture has to be assessed, the complete blood picture has to be taken, because I told you the liver function test, the liver ultra, so the platelet count may occur, thrombocytopenia may occur, so the full blood picture is mandatory. Liver function test has to be done, and the HCV, HBV, and HIV viruses has to be screened for, and immunoglobulin levels have to be checked. The tuberculosis is one of the most common opportunistic infection which occurs. Now, patients suffer a lot of opportunistic infections. One of them, tuberculosis, is very common in the patients undergoing biological therapies. So, try to take the chest radiograph and rule out tuberculosis. Okay, and if there is a necessity of vaccination, do it before starting the treatment, not during the live vaccine. If you have to give, you have to give inactive and attenuated vaccination. Okay. Then what are the adverse effects that we can expect? We have already discussed a lot. I'm just summarizing them. There may be hypersensitivity reactions, including anaphylaxis. So expect that and be prepared to handle it. No, keep your armatorium, the drugs or the doctors or the hospital ready for that. Okay. There may be a reactivation of latent tuberculosis, or a new tuberculosis infection may occur. So you have to be careful for that. Some opportunistic viral infections may reactivate. The cardiac failure may exacerbate. So you should be mentally prepared what all events are possible. Okay, there is a risk of malignancy, especially lymphomas. I have already discussed about them, or the malignancy, what is their concept and what is the controversy there. There may be cutaneous and mucocutaneous reactions, including lichenoid reactions, some vascular diseases like erythema multiforme, Steven-Johnson syndrome. Fungal opportunistic infections occur. More than candidiasis, histoplasmosis is seen in the endemic areas, right? Whichever area is endemic for whichever opportunistic infection, the patient in those areas are prone to develop those opportunistic infection. Like some parts of Northern America, histoplasmosis is common, so they develop histoplasmosis. Where mucormycosis is common, they develop mucormycosis. Candidiasis is seen, and cases of progressive multifocal leukoencephalopathy has also been reported. So we should be prepared for all these events. Then what all we should monitor? Seeing the screening and the adverse effects possible, we should monitor early signs and symptoms of any infection throughout the treatment, because there are high chances of opportunistic infection. You have to see the new onset and exacerbation of cardiac dysfunction. Keep monitoring the cardiac status of the patient and the CNS demyelinating disorders. Keep checking for the evidence of malignancy through the proper or authorized or standard screening programs of the malignancies, and full blood cell counts, liver function tests are as indicated by the history, or any other test that needs to be done. This is the article ID O'Neill and Scully by Neil and Scully. It is a invited review in the Oral Diseases office. Biologics in Oral Medicines, Principles of Use and Practical Considerations, and Oral Diseases. Okay, in Oral Disease 2012. So please see it. For all these guidelines are given in this book. So if you want to refer, you can refer this article to see the what you call that. 1 second. I'm sorry, I'm stopping for a minute. Okay, sorry. So basically what you have to review all previous and current medications, including vaccination. You have to obtain fully informed consent. You have to screen for the cardiac function, tuberculosis, virus infections, full blood cell counts, and liver function tests. And you have to be planned and ready for dealing with the acute reactions of biological agents. During biological therapy, you have to monitor every 3 to 6 months cardiac function, neurological status, blood count, liver function test, and CD4 cell counts. And tuberculosis screening has to be done annually. These were regarding the guidelines, okay, for general uses. What's happening? I'm sorry. Now, what has to be done in oral medicine? We have seen so many guidelines, such as strict guidelines, and so many indications, so many adverse effects. So where do we fit in our field, that is oral medicine? What are their uses? How they can be used? We are confused like this cartoon character. When I put in this slide, I did not know who this person is there. Today morning when my son was seeing my PowerPoint, he said that this character is called as Goku. He's from some Japanese cartoon character. No, I don't know. My son, I think, knows better than these things. So we are confused like this. Means where to fit in? Most of the time, the oral lesions are not as severe as they are seen. Suppose there is a pemphigus. They say that only severe recalcitrant cases. So in those cases, mostly they will involve the entire body. So on oral medicine, we see lesions when we try to stop the lesion when they are only confined to the mouth. Nevertheless, I'll explain the uses now, and you can decide on yourself that where we can use them or what precautions we shall take them. So let's see the uses in the oral medicine. Because the vista is limited, seeing the guidelines and the scope of oral adverse effects and the way they are administered, we need to, it is difficult to use them in a dental setup or a private dental clinic. You need to be in a hospital setup. If you're working in a hospital setup with specialized doctors who are trained in this, we can always use it in the oral medicine. So let's see where all we can use it. Most important is the pemphigus. For pemphigus, the most commonly used drug and most successfully used drug is rituximab. Right, I've already discussed this. There are various drugs in most of the recalcitrant cases or resistant cases or severe cases having more than 15 to 20% of skin covered areas where the pemphigus has covered the skin or where there were very high signs of Nikolsky sign present. In those cases, rituximab has shown very good results. It has also been used as a first line therapy in some drugs. Instead of using immunosuppressant drug, they have used only rituximab and they have got good results. So for pemphigus, rituximab is indicated, but with a caution that it is used in the severe cases. You can refer this article for the details, and there are a lot of articles and systemic reviews present regarding the pemphigus. And this is a systemic review what reference have given regarding the uses in the pemphigus, and most of them have shown a very good result for the rituximab. I think rituximab is given as a intravenous injection, and it is used in the uses of 375 ml per meter square area of the body. 375 ml per meter square area of the body. Okay. Then we use for pemphigoid, especially for bullous pemphigoid. All the data is available for bullous pemphigoid. It is because it is difficult to cure. No, it is more difficult to cure than, and yes, it is used, the rituximab is used both in pemphigus vulgaris and pemphigus foliaceus. Successfully, it has been used in both the forms. In bullous pemphigoid, omalizumab has shown very good result. Even rituximab has shown good result. Omalizumab is injected subcutaneously, 300 mg subcutaneously it injected. So I think we can use it in oral medicine when you have oral lesions. Some mucosal injections you can give, but you have to be in a hospital setup with that. So when we compare the systemic reviews, when they have compared the omalizumab and the rituximab, when they have compared omalizumab and rituximab, they have found that both the efficacy is equal, around more than 80%, 84% and 85%. That is a non-significant difference. But the chances of recurrence has been seen very less with rituximab, while the chances of recurrence within 6 months are more with omalizumab. So bullous pemphigoid has shown more recurrence with omalizumab after successful treatment than with rituximab. Omalizumab, when the injections are given in some patients subcutaneously, sometimes the local hypersensitivity reaction has been seen only at the first visit, not at the later visits. They have reported that at the first visit, the local hypersensitivity reaction was seen. So if given a chance, I think I will prefer rituximab, but depends upon the toxicity, that which is less toxic. Accordingly, you can use it. Okay. Then there is a periodontitis. Yes, periodontitis. There is a lot of controversy regarding uses of monoclonal antibodies. Obviously, we are not going to use systemic monoclonal antibodies for the periodontitis, where you're going to use topical versions. The MAB61 BZ1.3 is a monoclonal antibodies which has shown a good effect when applied topically every 6 to 8 weeks against Porphyromonas gingivalis. Porphyromonas gingivalis is one of the most virulent bacteria among all the bacteria which colonize inside the plaque. And Porphyromonas gingivalis has given is highly responsible for formation of periodontal infection. So this monoclonal antibody, when applied topically, has shown very good results against P. gingivalis and has stopped this proliferation. It has shown a better result when the flora has been decolonized with Porphyromonas gingivalis before application. That means you have to do proper scaling, root planning, and oral prophylaxis processes. And then if you apply this drug, then you will see a better result. The other drugs, sometimes some other monoclonal antibodies which are still in trial phases have been used against the protein integrins. They have used against protein integrins, which what the integrin does, that it starts forming the extension of junctional epithelium along the periodontal pocket and deepens the pocket. So just only the GTR is not enough. Sometimes if we add these monoclonal antibodies which are against integrins, then we stop the proliferation of downward proliferation of the apical migration of junctional epithelium, and the periodontal status is restored, and they show a good result. So these are two ways in which it has been shown beneficial in the periodontitis. Dental caries, right? Caries usually is not treated by medicine. There is no scope if caries is usually, no, if it has occurs, it has to be treated by restoration, or it can be prevented by proper oral hygiene methods. Still, there is a bacteria, you know, that is Streptococcus mutans. The Streptococcus mutans is responsible for the caries formation, and it has a protein called glucosyl transferase. Glucosyl transferase proteins are present inside the Streptococcus mutans, which are responsible for its virulence. So the virulence factor of S mutans is defined by the protein GTF, and GTF-B is the most virulent amongst all the GTF present in that mutants. Some monoclonal antibodies theoretically in vitro has been found to stop the growth of GTF-B and decrease the virulence of Streptococcus mutans. So if those monoclonal antibodies, when in the study you can find the evidence that when they were used against the GTF-B of the S mutants, the S mutants stopped growing and they showed a good result. So they have proposed that this antibody can be used as a vaccine against the dental caries. It is still proposed. There is no, I could not find any further articles regarding that. Probably if I would have searched more, I would have got it. If it interests you, you can search and you can read about it. But this is the proposed theory in the uses of dental caries. Then you come to Sjogren's syndrome. Sjogren's syndrome, all of you know, is an autoimmune disorder. And we have seen that all these drugs are very well used in autoimmune disorders. Rituximab, Epratuzumab, Belimumab, and Infliximab, all these drugs have shown good results in Sjogren's syndrome. When given for 6 to 8 months or 4 to 6 months in systemic doses, when they've given, they have shown good recovery of all the other signs like arthritis and all. Dry eye has recovered, patient has stopped, the lacrimation has restored, and salivary flow has been restored in those patients. So I think it is a good news that in Sjogren's syndrome, if the salivary flow is reduced, the patient's quality of life, comfort, everything increases. So these drugs have been used, and if you want to read further, you can refer this article in the Rheumatology, which is again a systemic review regarding the different drugs used in the Sjogren's syndrome. Then lupus erythematosus, rituximab has shown good results, while epratuzumab and belimumab, these two drugs have been used. Some articles say they are good, some articles say they are not good. Means some studies have shown that they are beneficial, some studies shown that they are not beneficial. Rituximab has shown some beneficial effect. Though, so I cannot say with 100% guarantee that the monoclonal antibodies works in lupus erythematosus, but yes, there are reports of them showing good results in LE. So these are the limited results which are used in the oral medicine, but most important is head and neck cancers, right? After all, the monoclonal antibodies, their primary mode, they are acting against cancers, right? So when we use platinum-based chemotherapy with fluorouracil and rituximab, it has shown a good survival rate when used as a first line in patients with metastatic squamous cell carcinoma. So in patients with metastatic squamous cell carcinoma, platinum and fluorouracil with rituximab has shown good results. That means rituximab has been given with a payload and it has given a good result. Cancers which are spreading with epidermal growth factor receptors, they also have shown a good result with the cetuximab and the cetuximab along with radiotherapy. They have shown better results of the spread of the cancer or the cancer, means the tumor evolution, the tumor, I'm sorry, I'm not getting the word. The tumor has disappeared or shown better results when the cetuximab has been combined with radiotherapy along with cetuximab alone. Okay, and HR3 is a humanized monoclonal antibody which has a good potential, remarkable anti-proliferative property, pro-apoptotic prophylactic and anti-genetic effective. So it can be used in squamous cell carcinoma because it increases the radiocuratability of the tumor. It is well tolerated, has a less adverse effect. It has a good angiogenic effect, pro-apoptotic effect, and anti-proliferative effect. So this medicine is being tried in the various drugs, and hopefully it will be available soon. So this was used in the head and neck cancer and oral medicine. Now, if you see this, this is a beautiful lake out at the outskirts of Bhopal. We call it Kaliasur Dam. It is known as Kaliasur Dam. Last week I had visited there, and we have clicked some pictures. This is my family. Last week we went there, and if you see this road, it's a lovely winding road like the Marine Drive in Bombay along the lake shore. But 2 days back, there was a news in the local newspaper that this area is now frequented by tigers. Actually, on the outskirts of Bhopal, there are a lot of hills. You can see along this lake that there are a lot of hills and forests. There are 6 to 8 tigers roaming around the Bhopal. And now the Kaliasur Dam, this particular road where we were standing, is being frequented by the tiger and is kind of stopped. So what happened last year? Something situation like this came. What you see in this picture, that a lady is standing in front of lion. I didn't get a picture with a lady with a zoo, lady with a tiger. What happened last year, that last year in the same area, government has announced that this area is tigers are roaming, please do not go out. But one lady, no, she thought of going for evening walk. When she went for a walk, when she came out on the street, she found that a tiger was staring at her like from 20 meters of distance. Now she was froze. What to do? She thought that her story is over today. To her rescue, or to her good luck, or she had some life saved life in her this thing destiny. When 2 guys were coming in the car behind her, they saw it. They stopped the car and they pulled her inside the car, like how they do in the kidnappings in the film, and they rescued her, returned and went. So why I'm saying this here, that we fear the tiger because it is killer. Seeing, we fear the unknown. Unknown is like a tiger to us. We fear, but when we come to know the unknown, we are able to tame the tiger. We come to know the properties of that unknown, we are able to handle it or tame it. So to fear, no, to our rescue came the different scientists and researchers, and they gave the considerations that what we do when we face a tiger. The tiger here is the patients undergoing monoclonal therapy who are having different types of symptoms, and the normal dentist, a general dentist which is not trained in it, doesn't know what to do when it visits the dental clinic. He's insured, no, he's not sure what to do. So for these patients, the guidelines have been given for dental consideration. Though the textbook, they say a warning has been displayed in their article that currently there is no standard protocol for dentists to follow in the treatment of these patients. Detailed analysis of medical literature has revealed that a guideline for treatment in some areas of medical exists, and it can be adopted to help create a guideline for the dentist. So let's see what are those guidelines. By knowing which guidelines we can tame that fear of tiger. So dental considerations, we have to be aware that potentially increased risk of adverse effects associated with interventional dental treatments can be there. We have to be aware that there are chances of adverse effects. See, why is dental consideration important? That though most of us, or most of the dentists, or most of you who are going to pass out, or those who are practicing, may not be using monoclonal antibody therapy in their practice. Some may not use in life, some may use later in life, some may get a chance to use once or twice. But as more and more men and patients in the general population are getting treated by monoclonal antibodies, or down the line a few years they will be being treated with monoclonal antibodies, there are high chances that you will be encountering those patients in your dental clinic, in your practice, or in your hospital facility. So the knowing that what precautions we should take and how can we serve those patients better is very important. It is very important to know that what all considerations we have to keep in the mind while treating those patients. That is the beauty of the oral medicine, that we teach all these things and how to practice them. So first of all, we have to be aware about the increased risk of adverse effects. Then if you encounter a patient, first and foremost thing is to directly consult that doctor who has prescribed him the monoclonal antibodies. If the patient is under biological therapy, you have to consult that doctor. Not only that, if he is not available, you can consult some other person who has more experience and expertise in this. If you do not have it, if you have it, well and good, very nice. Then you have to inform the patient regarding the adverse effects, that the use is off label and whatever the complications may occur, and you have to obtain a detailed informed consent from the patient. and you have to do detailed and thorough oral examination. It's not that patient came for caries and you see only caries. No, you have to do a thorough oral examination, because I told you that the chances of pre-neoplastic disorders, chances of lichenoid reaction, chances of Steven-Johnson syndrome, erythema multiforme, and some other mucocutaneous lesion or chances of development in neoplasia are there, and they can be seen in the oral cavity. So it is your duty to examine the mouth thoroughly. Okay, then and there is another school of thought which is coming, which is saying that why to expose this patient to dental treatment, like what we do for the patients undergoing radiotherapy for head and neck area. We send to a dentist, get his examination done, and remove all foci or possible foci of infection. Same should be done with the patients undergoing biological therapies. So if the patient is undergoing a monoclonal antibody therapy, before starting therapy, he should be referred to a dentist, and all his chronic foci of infection or possible foci infection removed, treated, and then he should be put on the therapy to spare off all the trouble. Okay, why this? Because infection is one of the most important side effects. Tuberculosis, viral and upper respiratory tract infections are more common. I have already discussed them, right? You have to keep looking for the signs and symptoms of the mycobacterial infection, and you have to keep looking the signs and symptoms for oropharyngeal candidiasis, histoplasmosis, or other atypical infections of the oral. There are no whole lot of opportunistic infections which occur inside the person. Okay. Then, right, lichenoid reaction, erythema multiforme, Steven-Johnson syndrome, malignancies and pre-malignancies are very common in such cases. You have to keep a high index of suspicion for neoplasia all the time you are seeing these patients in your clinic. But for most routine dental treatments such as restoration or some aesthetic work or orthodontic work, there is no specific concern. You can always carry on. No, just examine it, inform the doctor, talk to his doctor. You can carry on with your restorations, your aesthetic build-up, your smile designing, or orthodontic treatment. But when it comes to invasive treatment, then there is a problem. Why the problem is there? Because I told you already, the liver function gets altered with most of the drugs. So if the liver function is altered, the patient's all entire bleeding, clotting properties are altered, right? And so many, the metabolism of so many drugs are also being altered. So you have to be cautious while doing any therapy where the bleeding is involved. It may be implant placement, it may be a periodontal surgery, it may be a endodontic surgery, or it may be extraction of tooth or disinfection. So you have to take proper, you have to get the blood picture done, see for the INR up to 2 is accepted for such patients, that you can go ahead with this treatment. And you have to also be cautious regarding while prescribing the medicines, to avoid prescribing the medicines which are metabolized or excreted to the liver. Okay, then you have to see for that if the patient is under TNF alpha and agonists are being used like the Toximab, then the drug has to be stopped 4 to 5 times the half-life of that drug prior to any surgical process. That takes, for different drugs, it comes to 2 to 6 weeks. So you have to consult the concerned physician, and you have to stop the drugs 4 to 5 times the half-life of that drug. And it has to be restarted only after the surgical wound has healed uneventfully, satisfactory, without any remnant infection. If we are doing periodontal therapy, again, there is some controversy here. Some people say that when we give monoclonal antibodies for rheumatoid arthritis, it benefits more to the periodontium than to the arthritis. Okay, while so the periodontal status improves in those patients, while some other studies say that there is nothing like that has happened, no such benefit has been reported. Nevertheless, if it gets improved, well and good, it does not cause any harm to the periodontal status. Okay, there is no other concerns regarding post-treatment adverse effects in periodontal therapy. But when we are doing periodontal surgery, we have to take all the cautions that I have already described. Okay. In endodontic treatment, dental implant placement, or dental extractions or surgeries, there is a potential for post-treatment infection and other sequelae like osteomyelitis, or sometimes post-endodontic sepsis occurs. That is, the abscess develops after the endodontic infections, right? So it is advised that there is a perioperative antibiotic prophylaxis is recommended. This is not a strict guideline that you have to give, but to be on a safer side, it is advised that while you are doing the treatment, keep the patient under antibiotic prophylaxis so that you see less of the adverse effects, unless until it is contraindicated by the patient's status or by the doctor. Now come to the endocarditis risk, bacterial endocarditis risk. There is mild risk is stated, but antibiotic prophylaxis is not recommended. The guidelines say that there is no increased risk of endocarditis in patients which are immunocompromised, means the immune status is not determinantal for the antibiotic prophylaxis. So as the bacteremia during this thing, dental treatment is transient, the risk is less, so it is not recommended. Antibiotic prophylaxis is not recommended unless until it is recommended by the cardiac status of the patient. Means if the cardiac status of the patient says that antibiotic prophylaxis has to be given, it has to be given. But if the cardiac status says it need not be given, then just because the patient is on the monoclonal antibodies, it is not necessary to give those antibiotic prophylaxis. Okay, so with this I'll conclude. I hope you have learned how to tame the tiger of the fear of patients treating monoclonal antibodies. The monoclonal antibodies, to conclude, I'll say that they are a part of immunotherapy. They are a specific antibodies which are targeted against one single antigen. We deploy this antibody, those trained antibody inside our body, and use it. We use it in inflammatory disorders, in neoplasia treatments, and in autoimmune disorders. There are severe, sometimes there are very serious adverse effects associated with it. So we have to be careful while giving the drugs, and we have to follow all the guidelines prescribed in the literature. After that, in oral medicine, though, there are not much uses. There are uses, evidence of uses, and that has opens a wide area of scope for research. There is a lot of scope for research, and if you have the facility, we can try. Just because the literature is not available, we cannot say that the usage is not there. It's just it has not been explored. It is time for us to explore with lesser doses, with topical therapies, or with intrarenal injections. We can try those medications in the diseases or the lesions affecting the oral cavity. So that opens a vast area of research for all of us, and all of us, those who are able to do it, shall do it. Okay, then the most important thing is the dental considerations. We have to know, we must know that what has to be used when we encounter such a patient. Whenever we encounter such a patient, we must learn the precautions to be taken, the monitoring to be done in these patients. So I hope you have learned, and I am able to kind of sensitize you. I can't say that I have stated about monoclonal antibodies, but I have sensitized you, and it is for you to learn ahead with a lot of by putting your effort and making yourself expert in this field. Thank you all of you for the patient listening. I am thankful to AIMST University for giving me this opportunity. I am thankful to all my teachers. I am thankful to Amropin. Basically, I am proud to be associated with Amropin. Amropin stands for Association of Maxillofacial Radiologists and Oral Physicians of India. We are a group of mad, passionate people who are trying always to striving hard, madly to uplift our specialty of oral medicine, and make it aware, increase the awareness among the general people and among the medical and dental fraternity around the globe. The people from Amropin helped me a lot. Dr. Shikha Khare helped me by sending a lot of articles. There is always be untiring and never-ending efforts by the Dr. Ruchika, Dr. Mojit, Dr. Wasim, Dr. Ambika, and Dr. Prasanna. Thank you all from the Amropin. And I thank my panelists for their support, Dr. Vasanti, Dr. Pinakapani, and Dr. Shikha. And I thank my family for all the support they've extended. Now I'm open to questions, so I'll stop sharing screen, and I'll hand over the proceedings to the Dr. Priya.
Yeah. Thank you, Prof. Thank you so much. Thank you so much for your amazing talk. Yes, you need to take some water, hydrate yourself, Prof. It was very informative, simple, and easy for us to understand about like what is monoclonal antibodies. When this topic was put forth in the beginning, people used to ask me like, what is monoclonal antibody? It looks like a French terminology, but you have made it very simple and easy for us to understand, especially the undergraduates. And now I will invite Prof. Vasanti, Prof. Pinakapani, Dr. Shikha to open up for your panel discussions, the question and answer session. Please turn on your videos.
Good morning, to everyone from India and good
Hi.
afternoon to everybody from Malaysia.
Yeah. Hi, Dr. Shikha. Dr. Pinakapani.
Good morning.
Good morning, Prof. Prof. Vasanti. Good morning.
Good morning to all and hello to
Uh,
take some questions from you.
we can hear a little bit of disturbance in somebody's audio. Can you please turn off your audio? Yes. Okay, thank you so much. Yeah, the first question is to the speaker. Should monoclonal antibodies can be used as the first treatment of choice for the oral mucosal lesions?
No, I think I have already answered it during the guidelines that it should not be used as a first line of treatment. Though in some cases of pemphigus, one study says that they have used as a first line of treatment. It has to be used only in the refractory cases where their results are not coming from the regular medications or where the patient is not tolerant to regular medications.
Okay, so you mean to say like only in severe cases when the patients are not responding to any medications, we are supposed to give
then we should
monoclonal antibodies.
Antibodies, yes. That's what the current guideline says. It may change in the future with the timing and the more studies are available.
Okay. Yeah, the next question is again to the speaker, Prof. Nisheeth, sorry. What is the cost factor of monoclonal antibody? Is it affordable?
It is not easily affordable. It is highly expensive. Some say that it comes to around 8 to 10,000 pounds per week or per month, depending on the drug. Because the reason being that there are not many patients using it, not many hospitals using it. Laboratory costs are very high. So probably when the productions increase, the mass uses increase, the cost will come down. But right now the costs are very high.
Very high, very high. Okay, thank you so much, Dr. Prof. Nisheeth. And the next question is to Dr. Shikha. Monoclonal antibody is useful in the management of COVID-19. What is your stand on that?
Yes, nowadays they are now in use for the treatment of moderate to severe cases of COVID-19. And actually, the previously used itolizumab, which was used for psoriasis cases, has now been modified to use in COVID patients. That is only in severe cases. The drug mechanism is such that it attaches to the CD6 receptors and blocks the cytokine. So these cytokines are actually what is producing the fatal inflammatory response, which is the major cause of death in COVID patients. So the drug itolizumab is modified as such to block that effect. So even in India, it has been recently last week released and approved for use.
Thank you so much for the information, Dr. Shikha. And there is another question to Dr. Vasanti. Any considerations in the use of monoclonal antibody in viral infections, especially in viral infections? Hello, ma'am.
Unmute
Can
yourself.
you please
Unmute yourself, Dr. Vasanti.
you need to turn on your mic. Mic.
You are still muted, Dr. Vasanti.
Yes.
Hello.
Yeah.
In most viral infections, I feel that the use of monoclonal antibodies could be risky. Well, we are talking about COVID also right now. Considering the virus itself, we don't know how it will respond to monoclonal antibody therapy, but then it is preventing cytokine release is what is being supposed. So in that case, it seems to be useful. But generally, in the case of viral infections, unless you see life-threatening outcomes, it is definitely not indicated. And even in patients who are HIV positive, where immunity is already suppressed, I think use of monoclonal antibodies will worsen the person's immune status. So in case of viral infections, conventional treatments would be better. But if you are expecting an untoward response to the virus itself, then monoclonal antibodies need to be used with extreme caution in a hospital setting.
Thank you, ma'am. there's one nice question to Dr. Prof. Nisheeth. What do you suggest, Prof. Nisheeth? Is it vaccine versus monoclonal antibody? Which one is better for COVID?
For COVID.
Yeah.
For COVID is like, no, we are swimming in an unknown oceans. We don't know what all is there. Every day the symptoms are changing, manifestations are changing, cause of death is changing. There is no fixed natural history of the disease. And the vaccines, I have doubt because I am recently getting reports. Recently, I read a report from Germany where the doctors are saying that the patient can get reinfected. There have been reports in India also. Probably those reports are not coming forthcoming. So if the patient is getting reinfected with the virus, then there is no question of vaccine. So this whole thing is questionable for time being. And the monoclonal antibodies, like Dr. Shikha and Vasanti told, they are used only in the cases of cytokine storm, when it is at the very late stages where even dexamethasone is given. Now, dexamethasone is a immune suppressant drugs. Monoclonal antibodies are immune suppressant. They are used to handle cytokine storm when the patient is almost about to die. We cannot use it in the beginning. So monoclonal antibodies are definitely a no for COVID patients, unless until very serious, like what Dr. Vasanti has rightly said. Vaccines may be a chances provided that the reports of reinfections are not correct. If they are correct, then there is a question mark on that, and we have to live with it, I think.
Okay. Thank you, Prof.
May I just add on? I would like to just add on to it. As I understood it, that because it is already under research only, it has not been truly declared about the COVID management. So as I understood it, as monoclonal antibodies are basically providing passive immunity because they are like ready antibodies we are injecting in a patient, whereas vaccines are actually active immunity. So as the rule says of passive immunity, it will be very short term and used in the severely infected patients only. So for severe cases, I suppose monoclonal antibody would be better. And if the vaccine is developed and is working properly, then it is for the prophylactic use in the non-infected patients. So the the field of work is entirely different, and both would be useful, I suppose.
Thank you. Thank you so much, Dr. Shikha. And we are done with our questions. And can we have Dr. Prof. Pinakapani to give us a concluding message regarding this talk and how this monoclonal antibody works and what are the effects and what is the takeaway message for us?
Hello. Yeah.
Yes.
Very first thing is I would like to compliment Dr. Nisheeth for the excellent talk and what insight he has given about monoclonal antibodies. Now, as such, monoclonal antibodies are coming out as a very promising modality for treatment of various disorders, but their utilization in dentistry is very much limited. We further need to do a lot of research, and most of these monoclonal antibodies are still under trial phases. And of course, the point comes over here is the cost of the monoclonal antibodies. They are really very costly. For the time being, the takeaway message is yes, there are going to be many diseases in future which will be definitely treated by monoclonal antibodies. As we understand the disease pathogen, we need to understand what are the mediators which are involved in that and how to target these mediators so that we can win over the disease. So definitely, yes, monoclonal antibodies are having a good chance in future therapy and its utilization in dentistry. Other than that, I hardly doubt that in India right now, these pharmaceutical agents are being used so extensively. But yes, as a dentist, we need to be prepared because sometime in our clinic practice, we might have these type of patients who are receiving monoclonal antibodies, and we might miss out in our history, and it can be very disastrous in our practice. So yes, it's a good initiative by this university that you have conducted a program for an undergraduate student. At least many of our students would now know that there is something called as monoclonal antibodies, and their patients in their future practice might be one of them. That's it. So other than that, I don't have anything much input.
Thank you, Prof. Pinakapani, and I'll thank the speaker for today, Prof. Nisheeth Saawaran, and our panelist, beautiful three panelists, Dr. Shikha, Dr. Pinakapani, and Dr. Vasanti, for having you here and allotting us a time out of your busy schedule. Thank you so much. And I would like to share the next upcoming talk for tomorrow. Yeah. The upcoming talk for tomorrow is Applied Aspects of CBCD, the much awaited talk, an insight series by Dr. Sham Kishore from India. And I would like to thank all the undergraduate students, the academicians, and the clinicians who are like watching us for past few weeks. Thank you so much for patiently being with us for the entire program. And we'll be meeting you tomorrow again at 10:30 a.m. Indian time and Malaysia time 1 o'clock in the afternoon. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you so much.